Hello, everybody. So sorry. I had some technical issues trying to get online here. Thanks for waiting for me. I hope everybody's fine. We'll get straight into it. So I'm just going to share my screen. Uh, Oh, it's hiding there. Okay, here we go. So we're going to talk about error and harm today. Just put a thumbs up if you can hear me. Great. Thanks, Sarah. Leanne, thanks. So, patient safety. We're on to the sort of second half of this year. First half was on quality improvement. This is patient safety. They're kind of two sides of the same coin. But patient safety is probably had a lot more research into it, I would say, and probably more of a scientific approach to it. And it's a really rewarding area to think about because you can see the definite benefits that you can create. Probably the one biggest problem that you have with patient safety is that you are usually trying to prevent things. You're trying to prevent harm and errors. So it's a bit more difficult to demonstrate the value of your efforts when eventually what you achieve is something not happening. So trying to measure something that does not happen is difficult. It's much easier to measure something that is happening better than it was to begin with. But when you're trying to measure something that is no longer happening, like for example, prevented deaths, how do you actually prove that less people have died as a result of something? It's actually quite a difficult thing. So that's probably the one difficult area on patient safety, but it is very rewarding. Okay, so today we're going to learn about Swiss cheese model, talk about active failures and latent error, look at a classification system, and thinking about what this area is evolving into. So this is a definition of harm. See what you think about it, because it was from IHI. Unintended physical injury resulting from or contributed to by medical care that requires additional monitoring, treatment, or hospitalization, or that results in death. What do people think about that definition? Some nods of heads there. Yep.
I don't like that it only includes physical injury.
Yeah, okay, great. Yeah, I agree with you. So a lot of harm is psychological, social, and or even just like an opportunity cost that a patient misses out on something in the future because of the harm that they have received. So yeah, good point. Any other points, Blair?
Oh, sorry, I haven't got the camera going, but is medical too narrow? Should it be healthcare or is medical? I just think, could be wider than that. I mean, I think medical gets perceived one way.
Yeah, I agree with you too. So, I mean, there's social care that happens within the healthcare setting, for example, and there's lots of things that are not care at all, like I don't know, going up and down in the lifts or walking along the corridor and slipping and falling. That's nothing to do with medical care, but it's still our environment that we control. So, yeah, I agree with you too. So, yes. There's a couple there that you've already mentioned. So it also says something like the harm is unintended, but sometimes we do stuff knowing that it's going to end up with some sort of side effects, but we accept those side effects because of the overall benefit. You know, I mean, that's what we do in medical treatments quite often, especially like chemotherapy, for example. A lot of patients will get, you know, a peripheral neuropathy as a result of chemotherapy, but they accept that because of the benefits to their longevity. Still harm though, isn't it? Yeah, that idea that medical care causes harm, but there are other ways that you can have harm, and one is omission. So not doing something causes harm. That's not really medical care. That's a like I don't know, delay to care. So we've had a long wait list for some surgeries, and I've heard of actually some people dying waiting on the wait list, and some of them dying of the thing that they were waiting to be fixed. So that's harm. Harm is physical, but it's also psychological and financial, and also the notion that harm leads to additional care. But what if it was a minor harm and the patient just lived with it or got over it by themselves? I mean, that's still harm, even though it didn't require. So that original definition is a very very much from one perspective, and it's from the perspective of a healthcare provider thinking, okay, what is the burden of harm on me as the provider? He's not really thinking about what is the burden of harm to the person who's being harmed. So moving away from that definition of harm to a much more broader idea, and therefore trying to prevent that, is what the newer sort of patient safety sphere is about. And it also means that we can start to think about events that we think are unpreventable, actually thinking, no, maybe we can prevent them. So once upon a time, we thought that central line associated bloodstream infections were an unavoidable complication of care, i.e. we cannot reduce it to zero. But actually, it is actually preventable if you have the right systems in place for that. So how does harm occur? Well, harm and error are actually two separate things, because you can have errors that cause no harm, near misses. You can have harm that results, but we cannot really identify any sort of error that occurred before that harm happened. And then there's that one in the middle where the error and the harm are related in some way, sometimes directly, most of the time indirectly. So there are two types of errors, and the latent conditions are the sort of indirect things that we're talking about. These are the conditions around which you're working that lead to a riskier environment, that lead to an unwanted outcome more often. And these latent errors are more difficult to spot. Whereas active failures are things that have happened that directly, the consequences is harm. The direct consequence is harm. So it's like somebody pushing an incorrect button. But the thing to think about here is that although there might be a human being at the front of all this errors who's actually caused the harm, behind them is a system and an environment that has made that risky behavior possible in the first place. So this is a model that people probably recognize. It's the logo for the Healthcare Quality Commission. It's the Swiss cheese model. And what it helps you to think of is the system, the healthcare system has a series of fail-safes or safety nets to try and stop a patient coming to harm. So if there is a hole in the first defense, it's hopefully not lined up with a hole in the next defense, and they'll get caught in the next defense, and that will be what's called a near miss. But occasionally, due to chance, or maybe not chance, all the holes line up and the patient falls straight through all of the defenses and ends up in a harm. So that's one way to think about it, and I think it's a fairly good model for most of the time. And as I said, there are, in that space where the error and harm is associated together, there are many different types of errors, and this helps you understand what can lead to what. So the global term to collect all them together is an unsafe act, which is an error or a violation that's committed in the presence of potential hazard. Okay, so violations are deliberate. They are where somebody has chosen to do something despite their knowledge that they should not be doing it. And clinicians do that all the time. So we have guidelines to treat patients, and often we will decide, okay, we should violate this guideline because this patient has these sets of unique circumstances, which means that where they're probably better off if they do something different. And then there are errors. So this is where you fail to carry out a planned action as intended. Okay, so something, the outcome is a result is not quite what you wanted to happen. Okay, so then the errors are divided into two. One is that it does not go as planned. So you do the right thing, but it doesn't work out. So that would be a slip or a lapse. A slip being you've done something, but you've just not managed to do it correctly. Like often like a skill thing. So you've missed the vein when you're trying to cannulate something. That's a skill thing. A lapse is where you've got distracted, or you forgot to do something in the chain of events that meant that you ended up with the wrong outcome. And then the second type of error is that you do the wrong thing, but you carry it out correctly, but you just chose the wrong, your decision was wrong. And that's a mistake. So you added 1 and 1 and you got 3. That was a mistake. And the mistakes are divided up into two types of mistakes, a rule-based and a knowledge-based. So rule-based is that you got all the correct knowledge to put into your decision making, but you applied the wrong logic to that and came up with the wrong thing. So you had the information, the right information, but you didn't apply it correctly. And then the knowledge-based mistake is where you didn't have the right knowledge, or you had incorrect information to begin with. And so that led, even though your process in coming up with a decision was the right way to do it, you were always going to get the wrong decision because the underpinning knowledge was either lacking or incorrect. So that's a good way to think about unsafe acts. So maybe we could classify these. So if you could use the chat to put what type of error you think each one is. So if you just write, what it on each line, and then you'll know which one it is. So the first one being, you forget to tell your patient to schedule a follow-up appointment. You try to give your patient a pamphlet on healthy eating, but you grabbed the wrong one on sleep hygiene. You don't wash your hands because you're distracted. You don't wash your hands because you don't feel like you have the time. And the last one, you misdiagnose your patient's pain. just give you a moment to type your answers in the chat. Can't see anybody's answers yet. We're all waiting to see the answers. Okay, thanks, Rennie. Is it possible to display the types of error once more? Yeah, sure. Sure, sorry. Okay, here we go. So we've got violations, you've got slips, lapses, and mistakes. Okay, so just think of those four: violations, slips, lapses, mistakes. Okay, thanks, Sarah. So you think the first one is a lapse. You forget to tell your patient to schedule a follow-up appointment. And the second one, a slip. So you try to give your patient a pamphlet, but you give them the wrong one. Okay. Any other guesses? Rennie says number 3 is a violation. You don't wash your hands because you're distracted. Okay. Great. Okay. Well, Leanne says lapse, and a mistake, lapse, violation, and then lapse. Blair says slip, slip, lapse, violation, slip. Great. Okay. So we got some different ideas. Here we go. So the first one is a lapse. You forget to do something. Okay. So if you didn't forget, you would have done it correctly. It's not that you did the wrong thing, it's just that you forgot to do it. So it's a lapse. And then the next one is a slip, because you were going to do the right thing. You were going to give them a pamphlet. You just picked up the wrong one. That's a slip. Not washing the hands because you're distracted. Again, a lapse. It's the same as the first one, you're forgetting. The fourth one is the violation, because you knew you had to wash the hands, but you chose to go against that policy because of time pressures. And then the last one is you misdiagnose your patient's pain. That's a mistake. It's either a rule or a knowledge-based mistake. So a knowledge-based mistake would mean that you don't have enough training to make that diagnosis. You've not done enough reading on the different types of causes of this particular patient's presentation. Or another knowledge-based mistake would be that you didn't take a very good history. You didn't ask enough questions to get enough information to find out the reasons for the patient's pain. So you made the wrong diagnosis because you had the wrong information to begin with. Or it could be a rule-based one that you've just got it in your head that somebody presenting with this has a particular diagnosis, but actually your thinking is wrong. Your logic is wrong, and you need some more education to correct that logic. Okay, so So the approach to changing, to making things safer is a really much a systems approach. It's that's what the vogue has been for at least the last 20 years. So we're focusing largely on the conditions under which people work and care teams work, rather than individual sort of performance, which although is important, is something that you can't really deliver on a systematic scale and expect things to get better. So when you're trying to improve things and make things safer, you want to think about things that you can deliver across a whole system, not just to one individual. So this is where we design workflows and defenses to try and make the wrong action impossible to do, for example. We minimize conditions that lend themselves to violations. And we put mechanisms in place to mitigate the effects of unsafe acts. So if it's going to happen, is there something that can pick it up early to prevent it becoming a disaster? So this is why we try to take a more systematic approach rather than an individual approach, is because there's blame causing people to act defensively. And if people feel that they're going to be blamed for stuff, then they're not going to speak up about unsafe acts and things around them. And that is what will prevent you improving anything. Because if people go quiet and go underground, don't whistleblow and things like that, then you will never get to the bottom of why things are going wrong. So to counteract that, we try to have something, well, a lot of people have said, let's have a blame-free culture. So what do people think about that in healthcare? Do you think we could achieve a blame-free culture, or do you think that's necessarily appropriate?
I was just thinking, James, that probably we have to all be accountable for our actions, and sometimes if people aren't willing to take accountability, then maybe managers or other colleagues are in a position of having to kind of, as you say, whistleblow or point the finger. So it's hard to have a no blame culture at all.
Yeah. Yeah, I agree. I think it is counterproductive for safety officers and managers to go around saying, we're not going to blame you. Because whenever somebody comes up to you saying, we're just going to do this investigation about this thing that happened to, we're not looking to blame anybody, we're just trying to find out information. That's not 100% true. That's 99% true. But there is that 1% that, well, if you tell me something and and you incriminate yourself that you've done something negligent, then I am obliged to actually tell your regulatory body, who will then actually may have disciplinary consequences. So, for example, if a manager says, okay, we're just trying to find out what happened in this clinical incident, and then the doctor says, okay, well, if you're not going to blame me, I just want to say that I knowingly prescribed a drug that killed that patient. Well, now they have to be reported, don't they? So there is not a no blame culture, and there never will be. So that's where it's really, really difficult to undergo investigations into clinical incidents when a patient has died, and there are real possibilities that somebody could be blamed. I mean, it's very unlikely that somebody would get struck off from an incident unless they were being knowingly negligent. But I think it's much more common that somebody might come under a bit of heat from their regulatory body if they've done something wrong, or they could, lose their job, So there are actually new ways to try and conduct an investigation that try and soften this even more, to try and get more honesty coming out of the people, because 99% of the time what we just want is all the information so we can prevent it in the future. That's really what we're trying to do. One thing that this country does well is ACC. So ACC was set up with the main intention of trying to allow people to openly disclose what went wrong so that we can learn from it and do better next time. And it does do a good job at that. So there is very low rates of litigation of doctors and healthcare professionals in this country as a result of ACC, because they sit at the point of, okay, doesn't matter who was to blame, you as a patient are suffering and we need to compensate that in some way or help out so that you are not worse off from whatever has happened. And then on the other side of the coin, that allows the institution or the organization to get on with making the improvements rather than spending a whole lot of energy defending themselves. So I think ICC is a good thing. But yes, there has to be accountability, and that's where, you know, performance reviews come in and regulatory bodies and stuff to try and keep people in check. So it's a really, really interesting debate, that. So unsafe acts are a range on a spectrum, you know, in terms of what is clearly wrong and what is obviously nobody's at fault. So on the left of this chart, we have sabotage, malevolent, damage, suicide, you know, intentionally trying to cause harm. And then on the right-hand side, we got blameless error. Nobody did anything wrong. And then there's everything in between. There's substance abuse without mitigation. There's substance abuse with mitigation, possible reckless violation, system-induced violation, possible negligent error, system-induced error. So you can see that a lot of things on the left there will probably lead to disciplinary action of some kind, whereas there's a few things on the right that won't be. So there's a lot of unsafe acts that we gotta as a system, we've got to be able to pick out and then deal with appropriately, both on a disciplinary level and on a systems level. So the patient safety field has really broadened its view, because mainly we've taken the viewpoint of the person being harmed and saying what's important to them, rather than just thinking what is the impact on the organization of these errors and harm. So active errors are signs that latent errors are present. So that means if you see something that's happened wrong, it's likely that there's things around them and before them that's caused that thing to happen in the first place. That's the Swiss cheese model. And system failures that lead to serious harm are rarely the result of just one person. You know, it's typically a series of breakdowns. So now for something slightly different, we're going to look at what a zoo does around safety. And what does this teach us in the healthcare industry? I'm just going to play this. So let me just set this up so you get the sound.
We go outside of healthcare to see our system in a new way and get fresh ideas for improvement. Today we're going to learn about a safety system to handle a totally different hazard, one we rarely face in healthcare. We're going to look at dangerous snakes.
Hi, I'm Kathy Duncan, and today we're going outside of healthcare to the Central Florida Zoo.
The Central Florida Zoo has a lot to teach us about safety. Specifically, we're going to learn 3 valuable lessons about reliability. In order to create reliable systems, we need to prevent failure, identify failures and mitigate their effects, and learn from failure to better design our systems. How does the zoo apply those concepts when handling venomous snakes?
My name is Michelle Hoffman. I'm a reptile keeper at the Central Florida Zoo. I've been here for 4 years and I work with one of the largest collections of venomous reptiles in the Southeast within AZA Zoos.
Michelle took us behind the scenes to show us how they stay safe when handling snakes, to clean their enclosures and to move them.
The red and the green cage cards actually will tell us at a quick glance if the snake in the enclosure is venomous or non-venomous. So the red obviously is the venomous, the green is the non-venomous, red stop, green go.
And what's this number 1 up there?
The numbers above the enclosures actually tell the keepers how many animals are in the enclosure. So for example, there's only 1 Aruba Island rattlesnake in here and there are 3 pythons in that enclosure. So we know if we open the door and we only see 2 animals, there might be 1 hiding somewhere, to keep your eyes open and actually find all of those animals before you reach in or before you do any work in the enclosure.
All this helps prevent snake bites. But what if a failure does occur? When keepers handle snakes, they work in pairs so that if something goes wrong, there's a trained person there to help them.
We're expected to work really closely with our coworkers and our managers. We have a very open relationship when it comes to trust and being able to speak up.
They also use a belt clip with key information about the snake, such as the antivenom.
So that way if something goes wrong, somebody can come in from the outside, know exactly how to handle the situation and which antivenom to bring with you to the hospital.
This helps to reduce harm if a failure does occur. The next principle of reliability is that you may redesign your systems based on what you've learned from failures.
It's been over 20 years since we've had a venomous snake bite here at the Central Florida Zoo, and one of the reasons for that great track record is because we were always adapting and adjusting and learning how to improve our systems to prevent any failures in the future.
For example, they used to use a lanyard instead of the belt clip with all the snake information.
We actually switched it to the belt clip in order for it to be completely out of our way and not in any sort of position where it could get attached on anything or a snake's tail could get hooked around it or anything like that.
They also modified their trash barrel to have a plexiglass window on the top so that they could see where the snake is.
One of the main ways that we do learn is from other people, other facilities, other reptile professionals. So we are expected to have close relationships with those colleagues. If we have a system that maybe went a little bit wrong or that maybe wasn't working out the best, we can go to them and ask for advice without feeling like we're inferior or something like that.
Every time I visit the zoo, I see opportunities to standardize, mitigate failure, and even redesign the work. But they've taken opportunities to really look at how they can keep not only their keepers safe, but they can keep their animals safe. So as you go about your daily work and daily life, look at other opportunities to really see how you might can bring things back to healthcare.
Right. So, let me just set. I always find it really inspirational to find out what other industries are doing. It's a really great way to come back with ideas for your own place. And if you ever get an opportunity to visit another sector, and sort of see how they work, then definitely jump at the chance. So, so this video lists 3 principles of reliable design. Have you seen these principles applied in your areas, perhaps? Has anybody got any examples of safety? So they were talking about making sure the environment is conducive to safe working. So there's safe, there's the red and green labels. There's the number on the pen for how many snakes there are there. And then the second thing was learning from mistakes. So changing and modifying things And then the third thing was what they would do to reduce the harm if an error occurred. So keeping the antivenom, keeping that belt clip on so that they know exactly which one to grab, working as a pair. Yeah. So yeah, those are the three main areas. Leanne says, I come from manning safari lodges, and we use those principles too. Oh, interesting. That's really. Do you want to tell us a little bit more about your experience?
Yeah, well, I think also when you're dealing with guests, you've got to be ultra safe, and you're going into an environment where you don't actually know, a bit like actually pulling a snake out of a cage. I've done something similar. So you've got to know exactly what you're going to get into. So your principles are that you make sure if something happens, what your evacuation procedures would be, because you're often in an area where you're isolated. So there's always a plan in place. If an incident occurs, people back at camp, if you're out on safari and something happens, back at camp, they know exactly what to do, what steps to do. Before you go out, you make sure your vehicle is ready. You've got a rifle on in case you come into a situation where you need to use it, and that you've got all your equipment, such as a first aid pack, all those little things. We have checklists. We do similar things with that. You do a vehicle inspection every day before you go out. So yeah, things like that. And there's, I mean, in every, as well in camp, there's also things like that in place.
Great. No, thank you very much. That's a great example. So anybody else seen some of these principles applied in their areas?
So in radiation oncology, we have an actual radiation safety plan written out that covers a lot of these items. Everything from our building design, signage and warning lights, all the way through incident reporting and review.
Yeah, great. Thank you. Blair's just typed, for acute after-hours hemodialysis, we control either by environment staffing, number one, treatment carried out in ICU, two, if ICU not available for treatment, then we call in 2 staff to do this in the dialysis unit. Okay, yeah, very good. Yeah, good. Okay, moving on. So teamwork and culture of transparency and trust are important to protecting safety. We talked a lot about this today. How do you think teamwork promotes each of the principles of reliable design? So, reliable design would be these sorts of environmental things again that they're talking about, and how do you think they got to that stage, or how do you think teamwork helped them get there?
I work in mental health, so sometimes it's a little bit harder to see some of these events, I guess, that seem more obvious in hospital-based setting. But certainly that's something we rely on a lot here, is the kind of working as a team and knowing who's seeing patients in their offices and whether there's a level of risk with that patient. And then in terms of the program I work at, if we had a kid who was unsafe in some way, there's like an obvious chain of events that we would use in terms of accessing the manager, accessing doctors, EPS, that kind of stuff. So sometimes it's less environmental and more kind of patient management stuff in mental health. Yeah,
that's interesting. And so what would be like an example of an unsafe event happening in your environment?
We've had young people self-harm in our bathrooms before, or we had a young person decide to smoke cannabis in our bathroom in the middle of a group program, that kind of stuff. I guess environmentally, we've got things like meths that we use for cleaning whiteboards and things. We keep them in staff bathrooms and lock the doors. So like just those sorts of things. We've got knives on the shelf behind me that are for our cooking group, but not accessible at all times. So we have to factor in some things, but a lot of it's kind of teamwork and people being on top of that stuff.
Yeah, good. Yeah, no, that's a very interesting environment to work in, I would think. Yeah. Good. Okay. Moving on. So, what would happen if the zoo waited to redesign its systems until an actual failure? Not just the possibility of a failure. So, if it actually occurred, well, I guess that's obvious. It would be, quite a few people would need to be harmed before they actually made any improvements. So, in your experience, are health systems more proactive or reactive when it comes to addressing safety issues? It's a bit of a loaded question, I would say. Anybody got some views on this?
I would say that it actually depends on which area you're in, and possibly about your management of whether you're proactive or reactive. I think it's easy to just react. I come from in healthcare. I'm in the COVID vaccination space, and that was quite a new initiative that came out. So we were very reactive. We chose to take that route and try. We were open and communicative. We talked to our team, asked them what they found had happened. We'd have a debrief after every day to put forward ideas. So
yeah, we
I
call
think
that proactive, I think.
Yeah, we were very, very proactive. Sorry, did I say reactive?
Yeah,
We
you
were
did,
very
yeah.
proactive about how we did it. We didn't wait. And I think that because we were a new initiative, a new rollout, we did that. And probably my management style is like that. But so I think those factors do come into play.
Yeah, good. Yeah, it's not often you get an opportunity to set up a brand new service and kind of like try and do it the right way to begin with. Yeah, so that's good. Any other people have an opinion on the health system through their lens, through their perspective? I mean, it's always easy to focus on the negative and think, oh, we're just fighting fires all the time, and yeah, there's no time to sit back and do more of the good stuff and do prevention and stuff like that. And I think that is true. There is a lot of areas that could be improved, but also healthcare is also proactive in a lot of great areas. Like it's taken a long time for bowel screening to come online, but eventually there will be some massive health gains from bowel screening in preventing cancers, for example. So that's one proactive thing. There's lots of proactivity happening all the time, and it's probably just less interesting than the sort of reactive sort of disasters that happen. So like proactive planning, examples of proactive planning is a daily bed meeting and bed management, and trying to proactively plan for the day ahead. And if some activity and missions need to be cancelled because we predict that there's going to be a problem, then we're actually being proactive in preventing a patient safety situation where we have patients stacking up in a corridor, for example. So there's lots of proactive stuff going on all the time. But yeah, could we be more proactive in some areas? Yeah, good, I think. Okay. And last one to finish off the day, can you think of an example of a latent error from the zoo that staff took action to address? A latent error is something that's in the background that could contribute, but has not directly contributed to something.
Maybe having putting their Perspex in the bin lid. They probably didn't have any issues with having a snake rise up but knowing where it sits by being able to see.
Yeah, I think that would definitely be one. Yes. Yeah. Yeah, good. And maybe the other example would be like the lanyard, changing it to belt clip. Again, just improving the environment, but not necessarily would be the actual cause of the problem, but could contribute to any errors. So yeah. Well, that's it for today. Thanks very much, guys. And I do hope to see you next month, and carry on with the online learning. If you have any problems with access and things like that, just give me a shout out, and I'll try and help you. And sometimes it involves having to actually get in touch with IHI, which can be tricky. But anyway, any problems, just get in contact. Okay, take care. Bye.